Okay, everybody, welcome. So today we're going to talk about OCD, PTSD, ASD, also known as acute stress disorder. And the reason we're talking about these is these things share a common pathway. And so what we're trying to figure out is what's common about them and how do we tell? These are the mind's attempt to regain control when safety or certainty has been violated. PTSD and ASD, which is acute stress disorder, those are both typically trauma responses. OCD responds to threat perceived within. And that plays itself out through intrusive thoughts and that feels danger. So the reason we put these together is because someone like a patient with PTSD may ritualize safety behaviors that look obsessive. Or a patient with OCD may recount their first intrusive thought as a trauma. So as we understand this neurocircuitry overlap, fear, arousal, and cognitive control, this is going to help us diagnose with a little more precision as best we can for a field that's exclusively by exclusion, and it's all theoretical. So we try to be as precise as we can so that we can be as effective as possible. Now, the other thing, because this is a lifespan course, this is family psychiatry, you need to recognize that the presentation is different depending on what stage of life you're in. So children will act out their obsessions in play, whereas adolescents hide them in shame. Adults may intellectualize. Older adults may confuse the intrusive thought with an early cognitive decline. So your role is going to be to decode this based on the developmental language of distress that they're telling you. I'm going to introduce you to, it's not a new framework, it's the RDoC domains. I've told you about them before. That's the research domain criteria. And the reason I focus there is because in psych, we do a lot of psychopharm as PsycNP. So your psychopharm needs to be neurobiologically informed. You'll get a whole semester-long class on that. But this is the theory as to why you might be manifesting these signs and symptoms. So in the RDoC domains, we'll talk about negative valence, cognitive, arousal. I'm letting people in the room. And then we'll also do that 4P formulation again, because I really want you to ingrain that into how you take a comprehensive biopsychosocial history rather than doing checklist medicine. And by the end of this, I want you to be able to differentiate between acute stress disorder, PTSD, and OCD from trauma-related checking, essentially. And they're all going to be formed. And you need to tell the difference between anxiety and psychosis, because labels get misapplied and some are stickier than others. Now, the other thing to keep in mind is this lecture assumes you've done those 6 steps to making a diagnosis. Remember the 6 steps. Step 1, rule out factitious and malingering. Step 2, ruled out a substance-induced condition. Step 3, you've ruled out an underlying medical condition. Step 4, you are not pathologizing a normal reaction to a stressful life event, right, or an adjustment disorder. And step 5, then you go to a primary psychiatric disorder, and you're going to leave ADD for the last, and I told you why last time, but we'll reiterate that again here. And then step 6, just because they're odd and don't do things you generally do, that does not qualify as a mental disorder. So we don't want to just say oddly related is a mental disorder. Now, the objectives for this course, this thing today, is going to be what I want you to walk away with. I need you to think like a clinician. I need you to first figure out how to distinguish between PTSD, ASD, and OCD across the lifespan. This is the first objective. Now, if you only understand what drives the behavior, that's going to be a lot more helpful than just paying attention to what it looks like. The other thing is this 4P and RDoC framework. This is going to give you a structure as to where the symptoms can overlap, and I'll show you how to distinguish them. And then what we'll do is we'll talk about some psychotherapeutic modalities that can be applied depending on which diagnosis you're applying. But keep in mind, the biggest predictor of a therapeutic outcome is the therapeutic alliance. So you can kind of pick whichever one, but the ones I'm going to present you are the most evidence-based given the diagnosis. And then we'll talk about medication a bit, but I don't want to spend too much time on medication because, like I said, there's a whole nother course on that. So let's get this underway here. So this is not checklist psychiatry. We're going to approach this from a neurobiological perspective. So you need to think of this like it's disrupted circuits or disrupted systems. RDoC will help you see the machinery under the diagnosis. So this is a dimensional model. It's developed by the NIH. It's in the public domain. That's why I like it. I can use it for free without having to pay royalties. And it replaces that checklist formulation of the DSM. And the three main systems we're going to contend with are negative valence systems. The negative valence system, this deals with things like fear and threat circuitry. So think negative valence, fear, and threat. The cognitive system, as you recall, could be affected in ADD and anxiety, but the cognitive system deals with attention, working memory, and control. And then the arousal regulatory system, that deals with sleep, alertness, and autonomic tone. So all of these can be interplaying depending on the diagnosis. Finally, the positive valence and social processes, these are the things that govern reward and attachment. So this matters because PTSD and OCD are both circuit disorders of threat and control, right? There's a perceived threat and control, but PTSD reflects an overactivated threat response, whereas OCD reflects an over-controlled threat response. And these different expressions, same neural symphony, but different instruments are leading along the way. And I'll spell this out more as we go through, and I'll put up some comparison charts as well. So this is the RDoC framework as it applies to what we're dealing with today. And as you'll see here, three dominate this landscape of trauma and OCD. You've got negative valence, arousal regulatory, and cognitive systems. So each tells a piece of the story, and this is like the emotional physiology. So let's start with negative valence. What does that mean? This is the brain's threat. Fear, anxiety, and vigilance. In PTSD, it's in overdrive. You have hypervigilance. You have exaggerated fear response, scanning for danger that no longer exists. Pay attention to that. Scanning for danger that no longer exists. In OCD, though, this is misdirected anxiety, all right? This is anxiety about what? Internal threats. It's a hell of your own making, essentially. This is fear of contamination, harm, moral failure, and that is what's compelling the ritual and the control. Now, these originate differently. Same circuits screaming, something's not safe, but it's a different driver. There's also the arousal and the regulatory systems. And so why do we care? Well, even if the mind forgets the trauma, the body continues to replay it. So you keep acting as if the PTSD would say lives in the body, and it plays out in things like what? Disrupted sleep, heightened startle, autonomic instability. Guys, if you're going to yawn on camera, I see inside your mouth. So flip the camera, turn your head. I don't like touring your mouths. Okay, so OCD, this shows up as a physiologic disrupted response. There's tension and relief cycles. The same autonomic arousal, it's just ritualized into behavior controls because it makes me feel better when I do this thing. These both reflect dysregulated arousal loops. So the patient can't turn off. And the cognitive symptoms, that's the executive network. That's the brain's editor. When it falters, you lose control of the narrative. So in PTSD, the mind is hijacked by intrusive memories and, say, poor concentration. But in OCD, it's hijacked by intrusive thoughts and mental rigidity. In both, cognition stops filtering the threat. It amplifies it. Your thoughts are not reliable. So what's the takeaway then? Well, you need to think of PTSD and OCD not as two disorders, but as two dialects of the same neurobiology. Both involve threat detection gone awry. Both disrupt regulation. Both hijack cognition. And the task is for you to figure out which domain is dominant, because that's going to tell you where to intervene first. Okay. Once you get the neural circuitry The next thing you need to do is develop a clear picture of who it is you're treating. And this is that 4P formulation model that keeps coming back. So these are the 4Ps. You've seen them before, right? We're talking about predisposing, precipitating, perpetuating, and protective factors. This will help you explain that full ecology of the patient's suffering. So predisposing factors, this is the soil in which the problem grows, okay? So things like what? Genetics, early attachment, temperament, trauma, history, medical illness, learned behavior. This tells you what made this person vulnerable long before the symptom began. Predisposing, though, does not mean diagnosis. Now, they were doing fine until something happened. Until what? A precipitating factor. This is the spark that lit the fuse. This is a trauma, an infection, a loss, a major life transition, a stressor. In OCD, this actually could be an infection or a sudden fear of contamination. And we'll talk about that little carve-out nuance later on. In PTSD, the event that crossed the threshold from stress to trauma, that's the precipitant. Now, the question is, why did you show up? What has kept this problem going, and why hasn't this resolved? And those are the perpetuating factors where you will aim most of your intervention. So what keeps this fire burning? Well, things like avoidance, maladaptive coping, sleep loss, substance use, social isolation, some sort of reinforcement cycle they've built for themselves. These are the habits and environments that help maintain the disorder. Finally, you want to get some reassurance about their protective factors. These are like their overlooked strengths, and you want to spend some time eliciting them. Much like I told you in the first lecture in the BABE technique, H is what has helped in the past? How have you handled it before? And you'll get things like insight, maybe faith, coping, support systems, good neuroplasticity. They've done different things. They're engaged with the treatment, right? They want to come. They're looking for help. They're putting themselves in the right context. This reminds you that every formulation should not end with pathology because you want to give them some hope, but some potential. So that's essential when you're going to be done with you in 45 minutes, that you are building on strength to make it to the next session. This is a multifactorial approach, so I want you to use this to think very systematically. You're targeting biology, psychology, and environment, depending on where the perpetuating factor is. So at the end of each case, you're supposed to ask yourself, what predisposed this patient? What precipitated this episode? What perpetuates it today, and what protects them even from now moving forward? That's the sequence, so that you're not just doing GAD-7 checklist psychiatry. Okay, so here's the clinical approach. We want to organize around 3 principles. In a stepped diagnostic process, we want to have good lifespan awareness, and we have to practice trauma-informed care because the patient should not be worse off having met you. You don't want to re-traumatize your patient unless you've ensured good supportive mechanisms are in place. So stepped process. So because clarity comes from structure, you need to start broad. You need to screen first and then narrow them down. So you may use things like structured tools to protect you from bias because you can bring your own baggage to the session. They may remind you of the brother or sister or mother you don't like, and then you find yourself starting to relate to them. So we use structured tools as a means of trying to narrow the countertransference. And this is going to help you also identify comorbidities before you start chasing the wrong lead. Now, this fits into the RDoC framework because you're going to use that as a lens. It's not a label. You're not going to say arousal system disorder, but this is going to help you spot where the different manifestations of the biology are. Fear circuits, arousal dysregulation, intrusive cognition, all of that before you get that DSM code that you're going to attach so you can bill for the visit. That's what we need the DSM for. We need a code for the visit. In practice, you may use things like PHQ-9 to catch depression, but RDoC is going to give you this lens as to why. What's actually failing here? So this is the reason we have to be systematic and stepwise, is to make sure you don't miss anything and you don't prematurely pathologize or label someone. They should not be worse off, and the label itself can be harmful, because the other thing to realize is if you apply the wrong label, you will stop looking for other things. And so now you're stuck, and people get really married to their diagnosis. So don't do that. We're going to move from screening, structured interview, targeted exploration, and then we come up with that 4P formulation at the end. The other thing to pay attention to is where are we in the lifespan here, because symptoms evolve as the nervous system matures. So a child's compulsion may look like play, and adolescence avoidance may look like defiance. And then an older adult's hypervigilance may mimic the cognitive decline that they may be having. So we adapt the assessment language and treatment goals and even the metaphors you use to explain to the patient what might be going on. The other thing that's important is to remember this trauma-informed principles from our first lecture, because every interaction is either going to be regulating to them or re-traumatizing. So you want to make sure it's not the latter. So you use safety and trustworthiness. They're not therapeutic extras. They're essential to building this therapeutic alliance. That is the primary indicator. Okay, that is part of the treatment. Even in the assessment, you're doing a treatment. The other thing is you want to be very transparent. You want to explain to them what you're doing and why as you do this evaluation. The other thing is you want to be very collaborative. Let the patient participate in choices, even small ones, because you realize in trauma, what happened was they experienced a severe sense of powerlessness. It was done to them. So now you're trying to restore agency by getting them to help and decide even the smallest things. And then when you empower them, this reminds them that the very act of showing up is a form of control that's been regained. You chose to come here. I didn't make you do this. It's your willingness. I can only help you to the degree that you are willing. That's why I told you the first question is, what is it you're willing to do? And that's where you go. Don't try to force things on them, especially if they're coming from a trauma background. You have to realize, because the brain in trauma is reorganized around survival mode. So the goal is to help reorganize it and to form connections. The assessment, by the way, is not just data collection. It is part of the intervention. So the tone you set early on is going to either reinforce or mitigate that trauma narrative. So you want them to be able to mitigate that, rewrite a better narrative. So here we go. That's the groundwork, and we're going to move forward. So we're going to deal with post-traumatic stress disorder, acute stress, OCD. These all represent what happens in the brain's normal response to threat and uncertainty, but they get stuck. So we all have this adrenaline-like response. It's not bad. That's normal. It's when you get stuck that we have a problem. So PTSD and ASD are the brain's failure to deactivate, essentially, after trauma. OCD is the brain's failure to tolerate uncertainty and risk. So it's different stories, same central problem. It's a loop that won't quiet down. So we'll focus first on how each disorder manifests, what it looks like and feels like. We'll spend a little time on the neurobiology, and then that'll keep us moving forward. But also keep in mind this lifespan thing. So a 9-year-old, a 29-year-old, and a 79-year-old can all experience trauma, but the brains are going to interpret this entirely different because their capacities are different as well. So don't ask just what's the disorder, but what is the brain trying to achieve? So I have a podcast up you can listen to it, Depression as a Coping Skill. If you think about what the brain is trying to do, it's trying to manifest homeostasis. It's trying to feel safe. So maybe that checked outness is not them checking out, it's them not taking on new responsibilities. So the brain is trying to achieve something with the disorder. The body is always trying to survive, but it's maladaptive when it persists. So let's start with this question. What happens when the body survives something the mind cannot integrate? That is the essence of PTSD. It's a failure of the nervous system to turn off its alarm after the danger has passed. And the DSM gives us this criteria A as to what counts as trauma, but it's a direct exposure, witnessing or learning about real, threatened death, serious injury, or sexual violence. So notice how broad this is. This captures both physical events and the perceived threat to integrity or safety. There's also this criteria B, intrusion symptoms here. The trauma keeps replaying itself. Flashbacks, nightmares, physiologic reactivity, reminders. This isn't memory, though. This is reliving. This is the amygdala doesn't timestamp the event, so the body believes that it's happening now. The other criteria is criteria C, which is avoidance. Avoidance is not denial, it's a survival logic. The patient learns, if I stay away from reminders, I can stay alive. So that's what we're contending with here. Now, criteria D, this is the negative alterations in cognition and mood. This is the aftermath, the guilt, the blame, the detachment, and the sense that the self was somehow contaminated by the event. In other words, this is the identity they can take on forevermore. This is a sexual assault survivor who forever believes themselves to be dirty and unclean. Criteria E is the arousal and reactivity. This is the hypervigilance, irritability, exaggerated startle, sleep disturbance. The nervous system is permanently on call. And F through H, this is the duration over a month, clinically significant impairment, and not attributable to another condition. This makes the difference between acute stress and chronic reorganization of the self. So notice that it's an issue of timeline that is the distinguishing factor. So neurobiologically, what do we believe to be happening here? PTSD is, it's a memory system hijacked by the survival circuitry. It's the hippocampal axis. This is the stress response system misfiring. Cortisol is being released, becoming erratic, creating a state of chronic alarm without resolution. The amygdala is overactive. They're constantly scanning for threat, even in safe environments. The hippocampus shrinks under prolonged stress. That impairs contextual memory. The brain can't distinguish then from now. The prefrontal cortex, this regulator fails. That's the top-down control. It's diminished inhibitory control over the amygdala, leading to emotional disinhibition and poor impulse regulation. Pay attention to that phrase there, leading to emotional disinhibition and poor impulse regulation. Think about patients that might have that. And then what does this mean clinically? Well, for learning, fear learning has now dominated over safety learning. So the patient knows they're safe, but their body doesn't believe it. So RDoC, PTSD fits the RDoC map as a perfect storm of what we call negative valence, fear, arousal regulatory, hypervigilance, cognitive, intrusive memory impaired context, understanding that triad, negative valence, arousal, and cognitive. This allows you to tailor your intervention, say grounding for arousal, or maybe you'll do exposure to fear, or you do some cognitive reprocessing techniques for distorted meaning. So when you see a patient with PTSD, what you're really seeing is a biology stuck in survival pattern. So treatment is not about erasing the trauma, because you can't. It's about teaching the nervous system that the war is over. And that's going to take some time to learn. Okay, so if PTSD is the chronic echo of the trauma, what is acute stress disorder? This is the immediate aftershock. This is the brain's first attempt to make sense of what just happened, when the sense-making itself has been disabled. So this is a temporal criteria. So what defines temporally? The symptoms have to begin within 3 days of at least no longer than 1 month. In other words, within 3 days to up to 1 month, that's the time criteria to meet acute stress disorder. If it persists beyond that point, then you can begin to suspect PTSD. But in those first few weeks, the brain is in crisis management mode. Not yet pathology, but survival adaptation. Now, does everyone with trauma develop it? No, actually, most people do not develop PTSD. Many experience acute stress reactions, but acute stress disorder involves a certain level of dissociation so pronounced that consciousness itself fractures to preserve function. And that you need to have in there. Excuse me. So, what is dissociation? Well, because the mind's priority is containment, when experience exceeds capacity, it disconnects temporally from emotion, body, or memory. In detachment, this is the emotional numbing, the tunnel vision, the reduced environmental awareness. Now, you will see derealization and depersonalization. Pay attention to these definitions here. You may see them again. In derealization and depersonalization, the world feels unreal. The self feels foreign. There's a condition called dissociative amnesia. This is where the person may form gaps in the memory. They're missing fragments of the trauma. So is this maladaptive? Well, not at first. This is protective. This is a neurobiological emergency brake, if you will. But if it does not release, then the system gets stuck between shock and remembering. Then it's maladaptive. So what's the difference between acute stress disorder and PTSD? In acute stress disorder, you have dissociation dominating. The patient feels absent from their life. In PTSD, you have fear dominating, and the patient feels too present in the memory. Different poles of the same system. One numbs and the other relieves. So what do you do when you recognize somebody's having an acute stress disorder? Well, first, we don't rush to diagnose. You need to stabilize first. The early task is not to process the trauma. We don't need to rehash everything, but your job is to restore safety, orientation, and sleep. So if you want to do crisis intervention work, all of that lives in this acute stress disorder phase here, okay? This is safety, reorientation, and sleep. In many cases, with good support and containment, the nervous system is going to recalibrate and they may not progress to PTSD. So if PTSD is the mind haunted by the past, what is OCD? This is the mind trapped in the present. It's enslaved to the illusion of control. The threat isn't a past event, but it's a possibility that never ends. There is DSM-5 criteria for OCD, two components, obsessions and compulsions. Obsessions are the intrusive thoughts, images, urges that generate anxiety. And compulsions are the behaviors or mental acts performed to neutralize the anxiety. So when does this become pathological? It's a definition arrived at by consensus. But when this consumes more than 1 hour of a day, or causes clinically significant distress or impairment. So if you're doing something more than an hour a day, it could be an obsessive or obsessive-compulsive disorder. Now, we all have intrusive thoughts, but in OCD, the brain mistakes the thought for action as though imagining harm equals causing harm. Now, what about insight? The thing about this that's interesting is it ranges widely. Some patients actually do recognize the irrationality. Others are just very convinced of the danger. There's poor insight, meaning psychosis, and this means the obsession feels morally or existentially true. OCD is ego dystonic. It's really important to know that. They're aware that something's not right. And I make that distinction to distinguish you from OCPD, which we'll talk about when we get to the personality disorders. Those people think that everybody's wrong and they're going to fix them. What they're doing is right. OCD knows what's going on with them is not right, but they're distressed by it. OCPD thinks, I am the only one doing it right, and I'm going to fix all of you people. That's a major distinction. One's a personality, one is what we call a primary psychiatric disorder. We call Axis 1 in the old days. So just keep that in mind. Now, how does OCD map onto this RDoC framework? Well, the impairment would be the cognitive symptoms where they perceive impaired control, there's overactive error detection, their attentional bias is always towards a threat. Their negative valence symptoms may be they live in chronic fear of contamination, harm, or uncertainty. The brain's alarm is stuck on maybe it's a threat. Arousal systems are heightened. There's heightened sympathetic tone, physiological tension that's relieved only through the ritual. So it's not just a thought disorder, it's a full body state alarm. So what's happening in the brain then? Well, OCD centers on the corticostriatal cortical loop, the CSTC. That's the loop. It's a feedback circuit connecting the orbitofrontal cortex with the anterior cingulate cortex, the thalamus, and the basal ganglia. That's a loop that's going on. That's the neurobiological theory that we think is driving this. This loop filters and gates information. It's deciding which thoughts deserve attention and which can be dismissed. So what goes wrong here? Well, there's hyperactivity in the orbitofrontal and anterior cingulate cortices. There's a signal error when none exists. The thalamus then fails to inhibit the signal, and the basal ganglia reinforces the loop through habitual motor and cognitive patterns. So what's the result? This is the self-perpetuating circuit where doubt, then distress, and relief become neurobiologically encoded. This is like a neurohabit that forms. So we do chemicals to try and break this neurohabit. The compulsion is not madness, though. It's a neurobiology trying to self-regulate. The patient washes, checks, not because they believe this act is rational, but because it briefly silences the crazy loop. So why this matters is because every intervention you do is designed to retrain that circuit. Exposure weakens the error signal. SSRIs say will dampen that loop of hyperactivity. We're not erasing the obsession. We're teaching the brain to just let it pass. And part of the treatment is I have to check the stove. We're going to sit here for 60 seconds and not check the stove. I can't touch that thing on the ground. Let me put this M&M on the ground and now put it on your desk. And we're going to sit there for 60 seconds and watch your head not explode. And then you're going to build the stress tolerance. Question in the chat. Do you ever flag symptoms as positive for patients, or is that counterproductive? Your compulsions are your mind's attempt to reducing your anxiety. So you're on some level, so your brain is trying to help you. Not quite that positive. No, because then the problem is it could become virtuous. So the brain is trying to restore homeostasis, but it's stuck in a loop is about where I'll go with that. All right, so let's compare the neurobiological circuits here. So we've looked at conditions one by one, but what happens now side by side? So take a look here. So the same networks, fear, regulation, cognition. These appear again and again and again, but each disorder hijacks them in a slightly different way here. So look at PTSD and ASD. This is trauma-based disorders. The amygdala here is the overactive sentinel, okay? Constantly scanning for threat. The hippocampus is the faulty historian, unable to timestamp the memory, so the past continues to intrude on the present. You have the prefrontal cortex. This is the regulator. He's on strike or underactive, underperforming. He's failing to calm the alarm. And the clinical picture that dominates that they come see you for is fear dominates. The body doesn't trust any safety cues. All context is lost. Emotional regulation collapses. And the PTSD feels like they are living in the war zone long after the battle is over. Whereas in acute stress disorder, those same circuits misfire early, may normalize once safety is restored quickly. On the other hand, you have this OCD bit where the problem isn't re-experiencing the past, it's anticipating catastrophe. So this loop, this corticostriatal thalamic cortical circuit, acts like a malfunctioning error detector. It's unable to turn off the something's wrong signal. The orbitofrontal cortex is amplifying uncertainty and moral doubt. And the basal ganglia, which should automate the habits, get stuck in this repetitive loop and rituals become neurologically reinforced. The OCD brain is not overreacting to trauma. It's overreacting to the possibility. It's not fear of what happened, but it's fear of what might happen. And the compulsion becomes the strategy to neutralize that imagined danger. So it's a lot about perception. So how do you distinguish these things? So disruption in negative valence, fear and arousal system, hypervigilance, that's the PTSD, ASD dysfunction. OCD is a disruption in cognitive symptoms, error detection, and inhibitory control. So in simple terms, PTSD is a disorder of fear and memory. OCD is a disorder of error correction. Both are about safety, but one tries to escape the past and the other tries to prevent the future. Okay. So here are the structures in the domain. So this chart brings the theory down to a level of what does it look like, manifestations, what you'll observe, hear, or feel in the room with a patient. So negative valence response to threat aversion. What happens when the brain's threat system goes offline, or rather gets stuck online? In PTSD, it's fear to triggers, emotional numbing, collapse into avoidance. The body is still fighting yesterday's war. But in acute stress disorder, the system fires hard and fast. Intense fear, detachment, temporary overwhelm. Think of this as a neurobiological concussion. Most recover, but some don't. In OCD, threat detection is misapplied. The danger isn't real, it's imagined. Contamination, moral failure, harm. Negative valence here becomes the moralized anxiety expressed through rituals meant to neutralize what if, what if. Okay. And you'll see patients do that. What if, what if? You'll see that circuit fire. How does this body show? So in PTSD, what you have here is hypervigilance, exaggerated startle, broken sleep patterns. The nervous system cannot find the off switch in PTSD. In acute stress disorder, arousal is acute and disruptive. Patients might be agitated, irritable, unable to rest. This is the restlessness, or what we call psychomotor agitation. In OCD, the arousal response becomes cyclical. Anxiety rises until the compulsion and then briefly falls. This is a maladaptive tension reduction loop that teaches the brain only the ritual brings relief. These different conditions, same physics. High energy systems, everyone's looking to calm down. Now, what about here in terms of the cognitive domain? Well, cognitively, PTSD brings the intrusive memories and flashbacks. The past invades the present. In acute stress, this brings the dissociation and amnesia. The mind distances itself to survive. OCD is what brings the intrusive thoughts and mental rituals. The cognition's turned inward. So that's the pattern. PTSD is the intrusion of reality. ASD is the escape from reality. And OCD is trying to control the possibilities. Okay. Now we have to talk about some medical mimics because I told you sometimes we can trigger something medically. So before we diagnose PTSD, ASD, OCD, always make sure you've ruled out that underlying medical condition and substance induced. So if you skip this step, you might miss something. So a condition called Huntington's disease. I gave you that underlying medical conditions with psychiatric manifestations lecture, but it bears repeating here because this is how you might see. Huntington's disease is a progressive neurodegeneration, and it can produce obsessive or compulsive behaviors manifested by irritability and cognitive decline. So what's the difference? Well, here it's a genetic etiology of motor signs. You get choreiform movements. That's coordination issues, and then they gradually deteriorate over time. Someone with Huntington's may have their first manifestation as a psychiatric symptom. So always consider family history because it's heritable. Another condition to consider that looks a little like this is Tourette syndrome. This is a primary movement disorder with multiple motor and vocal tics. Patients often describe a just right sensation, an internal tension relieved by the tic. It can look like OCD, but the underlying drive is sensory motor, not cognitive. Still, the comorbidity is high. Up to 50% of people with Tourette's will also have OCD, but the key is to figure out whether it's meant to relieve an urge or reduce a fear. That's the distinction. There's another condition called Sydenham's chorea. This is a post-streptococcal autoimmune condition involving choreiform movements and emotional lability. So when you're doing a medical history, have you had strep throat or any infections, or have you been on antibiotics and the behavior then came after the infection, this is something you should think about. Obsessive compulsive symptoms can also emerge transiently, but they tend to resolve when the infection is treated. So that means you always need to ask about recent strep infections or history of rheumatic fever, because you're held to this higher standard of ruling out underlying medical conditions. And you don't have to do the workup, but you need to ask the question and facilitate the workup maybe. Another condition that seems to be controversial for some reason, but does exist, and I've encountered it 3 times now, PANDAS. Pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. That's why they call it PANDAS, because that name is too long. Okay. This is the sudden onset and dramatic overnight development of OCD symptoms, tics, and separation anxiety in a child who is previously well. I told you in the beginning, we don't really have psychiatric emergencies. If something comes on fast and furious, it's not a psychiatric problem. That's a medical problem. You need to get them into the right medical care. We don't have, I was fine yesterday, today I'm not fine. We don't have that in psychiatry. We have, I've not been doing well for at least a month. That's what we have in psychiatry, okay? So treatment often involves antibiotics and standard OCD interventions because they can habituate the maladaptive behavior. And in any child with abrupt onset of compulsions, consider an immune-mediated cause before labeling a psychiatric disease. The labels are sticky. The last thing you want to do is cast that die too early. Substance-induced presentations are worth noting as well. Stimulants like methamphetamine and cocaine can cause repetitive behaviors, paranoia, intrusive thoughts that look like OCD. Hypervigilance and flashbacks can also mimic PTSD symptoms, but unlike trauma, symptoms tend to resolve when you stop using the cocaine. So you need about 4 to 5 half-lives of a drug to make it completely out of the system. Cover that in psychopharm. Cannabis is another one. I told you it's practically in the salad greens. It's everywhere now. Cannabis can provoke anxiety, paranoia, and depersonalization. Hallucinogens, they can create symptoms like flashbacks, like re-experiencing. And then alcohol withdrawal, that can mimic hyperarousal, because what is alcohol but a central nervous system depressant? And all of a sudden it's not in the system, and that central nervous system is in overdrive. And you get things like sweats, insomnia, irritability, all easily can be mistaken for PTSD. I'm really anxious. I don't know what, okay, PTSD, but I need alcohol and that solves it. The safeguard is a toxicology screen and timeline correlation. So that's how you work a toxicology into your psychiatric evaluation, because you don't want to start chasing things when they're taking drugs that are working against you, essentially. So the main thing is, before treating the mind, check the body. Psychiatric labels and diagnosis are of exclusion. You just don't assume it. They shouldn't come to you with, I have PTSD, I have anxiety, stress, I have OCD. No, no, no. That's for you to decide. You want to hear, what are the symptoms? So at any one time someone comes to you and says, I have, fill in the diagnosis, your question is, how do you know? What is it that's going on that makes you think you have it? How would I know you have it? That's what you're listening for, because you want to get a timeline and capture the 4 Ps and the like, okay? Okay, so differential diagnosis. So for now, We've looked at this architecture of circuits and biology, but now we need to do the psychiatry bit. That's what we're all here for. So what is a differential to keep in mind here? What we're learning to do is pick up patterns so you can discriminate patterns of control and meaning. So you want to ask yourself, in PTSD, is this person trying to escape a memory? In OCD, is this person trying to control uncertainty? Both involve the anxiety and repetition, but the logic is different. And you want to figure out what their logic is in doing what they're doing or not doing. Through structured comparisons, timelines, triggers, content, relief patterns, what makes you feel better, and of course, emotional tone. And so you'll ask yourself, you'll ask the patient questions like, what happens if you don't do the behavior? You can maybe separate one disorder from another. So think of this next section as a little bit of craftsmanship. We're going to move from recognition to reasoning. I don't want you to memorize criteria. Okay, so here we have all of them on a slide. Okay, so here's where everything comes together. This is not about memorization. What we want to do here is disentangle the symptom overlap from the core pathology. So let's start with PTSD because it's all the rage. Think of this as the re-experiencing avoidance hyperarousal. It's fear-based memory disorder. This is the nervous system replaying a completed threat. Very important. Symptoms last more than 1 month and often become chronic if untreated. So the evidence-based treatments here are going to be things like SSRIs, SNRIs, eventually prolonged exposure, cognitive processing therapy, and EMDR. That's for PTSD. Acute stress disorder, this looks nearly identical to PTSD, but the timeline is the giveaway. 3 days to 1 month post-trauma. You have to have a trauma. This has a dominant feature of dissociation early in the picture. The person can feel detached, floating, not real, etc. This is the nervous system in emergency mode, acute mode. Treatment is brief. You focus on stabilizing. You help the patient reorient, reestablish safety, and avoid premature exposure work. Don't go back and re-traumatize them. Tell me all the dirty details. Don't do that here. They're trying to get away. It's a coping mechanism. OCD, on the other hand, this is on a different axis. This is on control rather than fear. The patient isn't haunted by the past, but consumed by what might happen in the future. Obsessions will create the anxiety. The compulsions will reduce it, but it's only temporary. This is a chronic course. It's often bimodal, childhood or early adulthood onset. Treatment here is high-dose SSRIs, and then we do things like exposure and response prevention. I can't touch the ground. Okay, I'm going to touch the ground and put this on your desk, and then we just sit there. That's the exposure and response. If PTSD seeks to escape fear, this is OCD here trying to neutralize the fear. Now, BPD, borderline personality disorder, tends to overlap with a lot of these features. There is talk and rumor about calling BPD, maybe we should call that complex PTSD. This is where emotion and relationship regulation fail. This is a pervasive, not an episodic situation. So that's what makes it a personality disorder, pervades all the domains. This is marked by emotional instability and fear of abandonment. And then there's major features of impulsivity. Now that sounds a lot like PTSD symptoms as well, but the anxiety here is not about contamination or trauma. It's about attachment rupture. Treatment here is DBT, schema therapy, no medications approved for any of the personality disorders. I put this here because these often get lumped in over time. The other thing is you don't want to diagnose children with personality disorders because their personalities are still forming. So if you do it prematurely, that's going to be a problem. I mean, kids tend to act a little narcissistic at times and a little borderline at times and a little avoidant at times, etc. So that's why we don't want to label that in children. Bipolar disorder, this is a classic imposter in the anxiety clinic. This is patients describe racing thoughts and insomnia that mimic anxiety or hyperarousal, but the difference lies in the episodic and polar nature of what they're telling you. There are going to be clear cycles of mania, hypomania, followed by depression. We'll cover that more fully in mood disorders, but the treatment there revolves around mood stabilizers and antipsychotics. So PTSD and ASD anchored in trauma. OCD anchored in doubt and control. Borderline, attachment abandonment issues. Bipolar, cyclical moods. Different origins, different therapies, but this is how they can sometimes overlap. And you can see how people get careless and start randomly applying diagnostics to things that they find difficult to understand. Now, I want to put these side by side here because PTSD versus borderline personality, these conditions will often get confused or coexist, not because they look identical, but because they live on the same emotional neighborhood street. Now, both involve trauma, affective volatility, and relational difficulties, but the architecture of suffering is different. So let me tell you about trauma. In PTSD, the root causes symptoms are directly tied to an identifiable event or series of events. Identifiable. If they're not identifiable, we can't label this. The reactivity is event specific in PTSD. It's a sound or a date, and each acts as a trigger that reawakens the past for them. Whereas in borderline personality, trauma is common but not required. Roughly 60 to 80% of individuals do report a history of trauma, but the disorder persists independent of triggers. So here, trauma may have shaped the personality structure, not just caused a discrete stress reaction. So PTSD says, this happened to me, and borderline personality will say, this keeps happening to me no matter who I'm with. So essentially, you are the main constant in all of your relationships. So maybe we should look inside. Now, there's an emotional pattern here. In PTSD, emotions are often reactive, and you'll see spikes of fear, guilt, numbness in response to trauma cues. It's defensive. The person tries not to feel. In contrast to borderline personality disorder, where emotions are pervasive and unstable. The person feels everything all the time. Mood shifts are rapid, intense, and often disproportionate to the trigger. It's not fear of the past, it's fear of a perceived abandonment in the present. That's the construct of borderline. And what about how they play out in relationships? Because this is really a good tell. In PTSD, they tend toward emotional withdrawal and mistrust. The patient appears detached, cautious, distant, connection feels unsafe. Whereas in borderline personality, on the other hand, the swings between, you're wonderful, I love you, you're perfect, now change, right? It's idealization contrasted with devaluation. Relationships are the battlefield for a borderline personality. Every bond carries the risk of rejection. Where PTSD hides from attachment, borderline personality clings in terror. So both struggle with trust, but for opposite reasons. And then how does this play out in terms of treatment? Well, in treatment, PTSD responds best to trauma-focused therapies because it's a target is the memory network, whereas once the trauma is reprocessed, symptoms will generally diminish. In borderline personality, we do things like DBT or longer-term therapies and their skills-based approach to rebuild those tools of how to emotionally regulate and develop some interpersonal boundaries. You're not just extinguishing fear memory here, you're reshaping the way the self is organized. They may call this identity diffusion problems, and we'll talk about that in the personality lecture. So PTSD is an injury to the system of safety, whereas borderline personality disorder is an injury to the system of self. Both begin with trauma, but they diverge in how the mind adapts or fails to adapt. So what about comparing here PTSD and bipolar disorder? Well, patients with PTSD often appear restless, sleepless, reactive. Patients with bipolar can look the same. But under the surface, this driver is entirely different. So in PTSD, again, trigger dependent, tied to trauma, reminders of perceived threats. Hyperarousal is contextual. The nervous system is reacting to a cue that feels unsafe. The patient says something like, it started after the car backfired. Or when I smell diesel, I can't sleep. In bipolar disorder, though, the symptoms are cyclical and internal. The episodes emerge with no external triggers. They're following some sort of biological rhythm, not a situational occurrence. The mania doesn't need a cause. It's here now. So the question you ask is, what starts the storm, event, or cycle? If there's some external trigger, that's likely not it. Except, of course, when you talk about time zone travel. Time zone travel can be a trigger for manic episodes, but we'll talk about that. The other thing is these arousal symptoms. In PTSD, again, it's fear-based, hypervigilant, exaggerated startle, insomnia rooted in nightmares or threat anticipation. They say things like, I can't relax. I'm waiting for something bad to happen. Bipolar arousal, by contrast, is energy-based. There's a decreased need for sleep, racing thoughts, goal-directed activity, and I am king of the world grandiosity. The tone isn't anxious, it's driven. I got a lot to do and I want to get it all out and I got to go. That's bipolar. So they might say things like, I don't need sleep. I feel amazing. I'm writing a business plan at 3 o'clock in the morning, 1 adrenaline and 2 dopamines, and I'm good to go. That's your bipolar person. The course of this is PTSD tends to be chronic and fluctuating with trauma reminders. There's usually a very clear narrative of before and an after, and these patients improve with trauma-focused therapies. Bipolar, on the other hand, is episodic with distinct beginnings and ends to the mood states. The symptoms will wax and wane, even without trauma, and there's often a family history, usually a first-degree relative, with a history of mood disorders. And treatment success is going to be pharmacological, dependent on mood stabilizers and atypical antipsychotics, not therapy alone with bipolar. Okay. Please don't vape. Okay, let's talk about this here. So, OCD versus GAD, generalized anxiety disorder, and then versus schizophrenia. So we talked about generalized anxiety last week. So here's one of the most important distinctions. When intrusive thoughts cross the line into delusional beliefs. The common thread across these 3 domains, these 3 disorders, are the cognitive intrusiveness here. But the organizing principle and the level of insight makes all the difference. So in OCD, the intrusive thoughts have insight usually. The obsessions are ego dystonic, like I told you, and they feel alien. They're unwanted, they're distressing. The patient knows these thoughts don't make any sense, but I can't stop them. The theme tends to be narrow and specific. I'm worried about contamination, harm, asymmetry, and morality. They tend to organize around those 4 obsessive domains. And then reality testing with someone in OCD is intact, though insight can vary from excellent to absent depending, and the compulsions are only there to neutralize the anxiety, not to express psychosis. The ritual is not pleasurable. Think of Mr. Goodall from As Good as It Gets. That's your picture for OCD. It's anxiety management through control, okay? Clinically, if the thought feels wrong but irresistible, that's probably OCD. In generalized anxiety disorder, this is worry without the ritual. So generalized anxiety, these are ego-syntonic. It feels reasonable to be worried about these things, even necessary. Patients here will worry about real-life problems, finances, health, the stock market, my relationship. But the worry is chronic and it's excessive and it's generalized. Reality testing is fully intact in generalized anxiety disorder, and the insight is good. So there's no compulsions, there's no magical thinking, there's no restricted themes, the body, no rituals that carry the symptoms. They might feel fatigued, muscle tension, and have some insomnia. So if the mind says something like, I should worry more, not I must perform a ritual, that's generalized anxiety disorder. But if they have to do something like a ritual, that's OCD. And then in schizophrenia, this is the beliefs beyond reality. So this is where the intrusive thoughts become false and fixed. Delusions are egosyntonic and unshakable. The person doesn't see them as irrational. Themes can be paranoid, bizarre, or grandiose, but unlike OCD and GAD, reality testing is also now gone. There's no if, there's no quality, only conviction. I am right, everyone is wrong, you don't understand. You may also see negative symptoms here in schizophrenia. So, flat affect, withdrawn, avolition, absent anxiety. Okay. So they generally will lack insight entirely, and they don't think they have an illness. They think they've discovered the truth, and I'm just going to tell all of you about it. So if the thought feels true, it's not intrusive, and the person builds their reality around it, that's psychosis, not anxiety. Okay? The thought feels true, it's not intrusive, and the person builds a reality around this thought process, this thought disorder, that's the psychosis. Okay? So OCD, I know this is irrational, but I can't stop. Generalized anxiety disorder, I know this could happen, so I keep thinking about it. Schizophrenia, I know this is happening, it's real. In other words, the difference isn't the thought itself, it's the person's relationship to the thought. Can a patient have pure obsessive compulsive disorder? Yeah, sure. As a standalone without generalized anxiety? Yes. All right, so here's our decision tree. So after all this theory, here's where the rubber meets the road. How do we actually think our way through a case? So when a patient presents with anxiety, intrusive thoughts, avoidance, repetitive behaviors, this is the mental roadmap you should follow. So you start broad. What is the entry point? First question, what's the context of the anxiety? Is it happening in response to trauma or independent of it? That's the single question immediately that divides your diagnostic path there. Trauma anchors the left side of the tree, okay? And absence of trauma, now you're on the right side of the tree. So if you say, yes, there's a trauma history, then we ask, how long has it been since the event? If symptoms appear within 3 days to 1 month, we call that acute stress disorder. Disassociation, numbness, emotional disconnection, etc. If they persist beyond 1 month, that shifts us to PTSD, where re-experiencing and avoidance are now center stage. Once PTSD is on the table, what comes next? You're checking for mood instability and relational volatility. If there are cyclic episodes of elevated mood, decreased sleep, and grandiosity, that's how we're suspecting bipolar. But if the distress centers on the fear of abandonment, unstable identity, that's who we're considering to be borderline personality. These aren't competitors to PTSD. They're often companions, but they change the treatment map a little bit. If no trauma, then we shift to the nature of the thoughts. Are they ego dystonic, experiencing unwanted and intrusive? And then that would point you to OCD. The patient recognizes the thought as irrational and tries to neutralize it through a ritual. If the thoughts are ego-syntonic, focused on real-life concerns about the future, finances, health, relationships, that's generalized anxiety disorder. Here, the anxiety feels justified, even productive, but it's excessive and it's unrelenting. So OCD worries feels absurd, but urgent. Generalized anxiety worries feel realistic, but endless. And then finally, we have to integrate the time, trigger, and tone. This is the triangulation you need to do. So how long since onset or trauma? That's the timing. The trigger, what activates the symptoms? Memory, thought, or uncertainty? Tone, does the experience feel alien, ego-dystonic, or logical, ego-syntonic? When you align these three, the diagnosis almost always reveals itself. So think of this tree not as a test, but as a conversation with the nervous system. Each branch is going to represent a different circuit gone awry. Fear, control, arousal, attachment, mood regulation. Your job isn't to force the patient into a category, but to just follow the logic of their suffering until it leads you to the right thing to do, the right intervention. Let's see the question here. This is all dependent on someone being able to identify a history of trauma, right? We don't call it PTSD until they can identify a history of trauma. Correct. Okay, so now let's take a look at the lifespan considerations that we need to pay attention to because you're doing family practice across the lifespan here. Development-specific approaches. So up until this point, we focused on the disorder itself, how they differ, how they manifest, how they overlap. But the real thing we need to know now is what are the patterns that shift with age? So the question now becomes, what does trauma, obsession, anxiety look like when the brain and the patient are at different stages of development? Okay, so the lifespan is not just the backdrop. This is the biological and psychological context that we have to consider that's shaping symptom expression, coping capacity, and treatment response. So, for example, a child's flashback isn't the same as an adult's nightmare. An adolescent's compulsion may look like a rebellion. The elder's avoidance may look like withdrawal. Some same circuits that we talked about in the RDoC, but different developmental scaffolding. So why does this matter? Because diagnosis without developmental awareness risks a misinterpretation. A preschooler's post-trauma regression could be misread as autism. A teen's risk-taking may be seen as bipolarity rather than chronic hyperarousal. And in older adults, cognitive decline can mask or mimic intrusive phenomena. So in other words, the symptom may be universal, but the meaning is age-specific. The next thing we need to think about in this section is going to be moving from childhood to late adulthood and tracking how trauma-related and obsessive-compulsive phenomena are evolving. Okay. And they're going to all determine, presentation and prognosis and things like that. Okay, so let's get into this here. So let's talk about children. When we assess trauma or OCD in children, the hardest part is remembering that these are not miniature adults. Their brains, their language, their sense of self, all still forming. So their symptoms will communicate differently. So first, how does it look differently? Children rarely identify obsessions as abnormal. You're not going to hear from a child, I have intrusive thoughts. I'm not going to say that. You'll see it in behavior, play, or drawing. So trauma will often show up as reenactment in children. They'll see regression, or they may have somatic complaints, stomach ache, headache, clinginess, etc. OCD may look like ritualized behaviors, lining up the toys perfectly, excessive hand washing, constantly checking on parents, but without verbal awareness of why. So the key is really observation. So you always want to see the kid with the parents and how they react. And then you want to observe them without the parents and see how they react, because all of that is going to give you context. You also want to talk to parents individually with the child and then with each parent individually, because you want to see, are the symptoms consistent depending on who's in the room, because it could change. The other thing you need to worry about kids is they're limited of verbal ability. You can't rely on an abstract self-report. Children think very concretely. So intrusive thoughts might be described as bad pictures or sticky thoughts, or not at all. They don't really have them. Well, they have them, but they're not expressing them. Assessment's going to require things like behavioral observation, caregiver input, and some developmentally attuned language. Instead of asking things like, do you have obsessions? Do certain thoughts get stuck in your head even when you don't want them? Stuff like that. Make it developmentally appropriate. Family accommodation. So here's the variable in the family system. Parents often participate in the ritual. So this provides reassurance and altering routines and avoids the triggers to prevent the distress. But what you've created is a cycle organized around this distressed child that keeps reinforcing it. That's why child therapy is most effective done in a family systems rather than individually. While the parents are well-intentioned, this is just simply reinforcing the maladaptive behavior. This is the same thing as my adult patient in his 20s whose parents keep paying off the gambling debt, so he has no reason to stop. I'm like, so what's the problem? You gamble, he loses, you pay. He gambles, he loses, you pay. Everyone seems to have a job here. We're good, right? Hard to break that cycle. So everyone's well-intentioned, but you can see how we're perpetuating. So treatment in this case is always going to have to involve parental coaching to gradually reduce the accommodation while maintaining empathy. Because in this case, you're not just treating the child. What you're doing is you're retraining the whole household. And household means all the people that live there. And of course, because it's a child, you always have to think medically when it's an abrupt onset. So if a child develops OCD symptoms, tics, regression following a strep infection, consider PANDAS. Screen for infection history, inflammatory markers, coordinate with pediatrics, ask about developmental history, immunizations, and the like. They may need CBT alongside the medical treatment of antibiotics to treat them. Another thing to keep in mind are the developmental factors here. So remember what's normal for the age. Magical thinking, bedtime rituals, and transient fears could all be developmentally appropriate depending on age. So you want to distinguish between normative rituals that are comfort-seeking versus pathological rituals, which are like anxiety-driven and inflexible. Pre-puberty OCD is often male predominant with higher rates of tic-related presentations. So context is everything. What's protective at age 5 could be pathological at 10. And now these treatment modifications. So therapy needs to fit in the cognitive level of who you're treating. So you need to use behavioral over cognitive strategies, modeling, games, exposure, hierarchies through play. And if you're going to do medication, you start at lower doses and titrate them cautiously and engage the patients and families as well, and you might integrate some play therapy and the like. Therapy is not about insight in children. It's about mastery through experience. So think about Erickson's developmental tasks of development. They call it task mastery at the different stages. Excellent book recommendation here from Dylan. It's called Breaking Free of Child Anxiety. It's in the chat if anyone wants the link. He gets royalties on the sales. No, I don't know what he's getting on the sales. Okay, let's talk about adolescence now. So adolescence is where trauma, identity, and autonomy collide. This is where symptoms stop looking cute and start looking dangerous or defiant. The clinician's task here is to discern from developmental turbulence, like normal adolescent teenage stuff, from psychiatric disorder, and to see how trauma and OCD attach themselves to these different adolescent struggles for identity, belonging, and control. So let's look at identity formation here. So we have to start with the person as they see themselves, because adolescence is this laboratory of identity. They think everybody's looking at them, but so do all their peers. During this stage of moral and sexual identity, they're under construction. And anxiety often migrates into scrupulosity. That is, obsessive fear of moral error or impurity. Adolescents develop this confession or apology ritual. They spend hours seeking reassurance about a sin and then experience intrusive sexual blasphemous thoughts that cause profound shame. These thoughts are almost always ego dystonic, but they feel morally damning. So what looks like religious devotion may actually be an anxiety disorder wearing a halo. So watch out for this sort of developmental behavior with respect to OCD. Another thing to pay attention in this group is this age where peers become the new mirror. So adolescents are exquisitely self-conscious, and the stigma around mental illness can make symptoms seem deeply private. So many will conceal compulsions or trauma symptoms out of fear of rejection or being seen as weird. You may see patterns of social avoidance emerge, either from trauma triggers, meaning they feel unsafe in crowds, or it could be an OCD-related contamination fear. But peer groups can buffer or worsen symptoms depending on whether the environment reinforces the shame or offers connection. Do not underplay the power of social contagion in this age group. Always ask not just how the teen feels, but who they feel safe with. Another chat box. Okay, let's talk about school impact and academic performance. So if you want to find adolescent distress, start in the classroom. Trauma or OCD symptoms often manifest as declining grades, perfectionism, or avoidance. Intrusive thoughts disrupt the concentration, and compulsions eat up hours that are supposed to go to sleep or study. Some adolescents will compensate by overachieving, spending excessive time on assignments out of fear of making a mistake. And then when symptoms escalate, you will see behavior like school avoidance shows up. It's not defiance, it's exhaustion. And the anxious teen doesn't drop out of effort, they drop out of tolerance, meaning they can't tolerate this hell of their own making anymore. The other thing to pay attention to in this group is risk behaviors and suicide assessment. This is the part you can't afford to miss. So adolescents with both a trauma history and OCD carry a heightened suicide risk. Intrusive thoughts may become intolerable, and self-harm may serve as a misguided attempt at control. The other thing to pay attention to in this group is substance use and risk, because this multiplies in an effort to relieve their distress, especially stimulants and cannabis. Every visit should include a comprehensive suicide assessment regarding ideation, plan, intent, and access to means. Also, you want to monitor this group for non-suicidal self-injurious behavior, NSSI. Cutting, scratching, burning. These are things that will often accompany intrusive guilt or emotional numbing. So when an adolescent says they're tired, they don't always just mean physically. They could mean existentially tired. And you all just had that lesson on existential therapy, so now you know. So the main takeaway here is in adolescence, trauma and OCD don't just shape the symptoms, they shape the identity. And your intervention has to honor the developmental task that they're in. And then you need to help the teen find control, connection, and coherence without sacrificing who they're becoming. Okay, let's do this here. By adulthood, these disorders rarely exist in isolation. They intersect with work, relationships, and identity, and that's what makes this adult presentation so clinically demanding. The goal in this group, this 19 to 64-year-old group, isn't just symptom reduction, but you're trying to restore function, stability, and purpose across multiple life domains. So, 80% have comorbidities with PTSD and OCD, and at least one other diagnosis. Could be depression, generalized anxiety disorder, substance use disorder. Those are the usuals. And this overlap is not diagnostic noise. It's often part of the pathophysiology because this chronic hyperarousal and intrusive rumination prime the brain for mood dysregulation. So if you're treating OCD and PTSD in adults, you're almost never just treating one thing. Comorbidity will shape your medication choice and the sequence of therapy and progress. The other thing you need to pay attention to here is occupational impact. Consider all of this and the toll on work. These are disorders that erode attention, reliability, emotional endurance, and you need all of that because that's the currency of employment. So adults may appear disengaged or avoidant when in reality, they're expending a lot of effort managing intrusive thoughts and hypervigilance. Career disruption, absenteeism, you'll notice disability claims here start to pop up. Part of the role is in advocating for the accommodations while fostering reintegration and being very sensitive to malingering. Because you'll notice the malingering will pop up here as well. Another thing to pay attention to in adults is this relationship effect. So chronic anxiety and trauma don't just live in the person, they live in the relationship that they're in. So emotional dysregulation and avoidance can strain intimacy, and partners will then misinterpret symptoms as withdrawal or criticism. Children may experience inconsistent parenting during a symptomatic period. So then family psychoeducation and couples interventions often become essential components of care in this population. Healing is going to require a recalibration of both the nervous system and the relational ecosystem around it, because this didn't just happen overnight. People adapt because the whole system is trying to establish homeostasis here. The other thing is substance abuse is not unique to teenagers. Adults use them too. And of course, there's this self-medication they do. This is the silent adaptive failures. So 40 to 60% of adults with PTSD report using substances to modulate anxiety or sleep. Alcohol blunts hyperarousal. Stimulants fight the fatigue. Cannabis numbs the emotional reactivity. And every short-term relief deepens that long-term dysregulation. So treatment has to include this trauma-informed addiction care, not sequenced, but together. So if you treat trauma, but don't deal with the coping mechanism, relapse is basically a guaranteed. It's inevitable. You have to treat both because that's what perpetuates the addictive behavior. And of course, we have this chronic nature because it's gone on for a long time. You can't ignore that 30 to 40% of adults develop this persistent treatment-resistant symptom. And for these patients, standard CBT and SSRI protocols are going to max out. So these people will need special approaches like trauma-focused CBT, maybe EMDR, maybe exposure therapy with augmentation, maybe some adjunctive neurostimulation. Chronic does not mean hopeless. It just means that the nervous system has adapted a long time, and we're going to have to spend some time trying to move past this. Finally, this age and stage here, the late onset, older adults. This starts with timing. So many older adults will experience their first presentation after a major life transition. So think things like retirement, bereavement, medical illness, loss of independence. Late onset OCD tends to feature fewer checking rituals and more hoarding behavior. So often it's rationalized as saving this for the future. And these cases are easily mistaken for neurocognitive disorders because both involve repetition, indecision, and executive dysfunction. The key difference, though, is that OCD retains awareness that the behavior is excessive. Dementia does not. So always ask, does the patient know it's unreasonable? If yes, you're likely dealing with OCD, not neurocognitive disorders. And of course, the elderly, you have to contend with medical comorbidities. The body and mind share the same stage. So cardiovascular disease, diabetes, chronic pain, sensory loss, all interact with psychiatric symptoms. Anxiety may rise from, say, dyspnea or an arrhythmia. Trauma reactivity may worsen with a medical vulnerability. Medical illness also constrains your pharmacologic options as well. So drug-drug interactions and metabolic concerns, hepatorenal clearance, all of that will require extra attention on your part. And then finally, these cognitive considerations. Cognition is both the foundation and the filter of treatment. So the problem is they may be developing a neurocognitive decline, which is reducing their insight, learning capacity, and therapy retention. So pharmacognitive screening is going to be kind of important because if the cognitive deficit is paramount, you may not get much traction with something like CBT. And then, of course, in the elderly, we have to deal with things like polypharmacy. Every pill has a ripple effect. Okay. Older adults, they face higher risk of drug-drug interactions and side effects and anticholinergic burden and QTC prolongation and serotonin toxicity. And there's a lot of CYP450 interaction problems that go on. So avoid medications that compromise balance, cognition, and cardiac rhythm whenever possible, because hospitalization can trigger also delirium. So that's a problem. And then finally, therapy itself, you know, you have to pace yourself accordingly. You have to simplify instructions, maybe use some memory aids, include a caregiver, family member aid if they have one. And these people will benefit more from shorter sessions more frequently than a long session once a week, kind of like we would if these lectures were not 3 hours long. So older adults present with quieter stories, but deeper layers. And so effective care requires good fluency with geriatric medicine and neuropsych. Okay. This will be our last slide, then we'll take a break. So now that we've looked at this across the lifespan here, you don't just rely on your intuition alone. Okay. Assessment starts with the language that fits best. So in children, for PTSD, these are some screening tools that you may want to consider. The UCLA PTSD Reaction Index. This blends both structured questions with child-friendly framing. There's also this CPPS tool for PTSD symptoms. This will quantify the frequency and distress for a baseline and follow-up. You're going to need some objective way to measure what are we treating and are we making progress. And these tools can be helpful. Take a look at the adolescent tools here. Insight improves, but shame increases. So the assessment has to balance that structure. So they may do better on checklists and that they check off answers rather than ask to their face, so tell me about your sex life. That's not going to help. So you want to maybe provide some discrete ways to collect the necessary information. But the most popular one is this adolescent dissociative scale when they have these symptoms dominating. For OCD, they use the SciBox for teens. These are all in the public domain, so you will decide which ones you become facile with, and you can adopt them. Adults will require some precision and not over-testing. So for PTSD, we use the PCL-5. Basically, it's the DSM-5 checklist criteria if you're going to use that. And then in older adults, PCL-5 also works. There's a geriatric version. The geriatric depression scale with PTSD is also available. This is essentially the key takeaway here. You need to choose the age-appropriate tool for data collection and make sure you're translating the language of symptoms into something that's developmentally appropriate. So the right instrument to build good accuracy and you don't over-diagnose. Why don't we take a break here for 10 minutes and then we'll come back and finish, okay? All right, welcome back. So here we go. We're going to get now to the issue of a comprehensive assessment in evaluating OCD and trauma across the lifespan. So when we assess a patient for trauma or obsession-based pathology, we're not just collecting symptoms. What we're doing is we're trying to trace the logic of the nervous system under stress. So a comprehensive assessment is going to aim three factors. You need to clarify the driving mechanism. Is it fear? Is it guilt? Is it arousal, dysregulation, control seeking? What are we driving this thing with? Then you want to differentiate it from overlapping symptoms. Is it intrusive trauma, imagery, real or imagined? And also you want to categorize what is the functional impact and the treatment leverage points so that you can be effective. Now, the core domain that you're going after is this temporal profile because it's all about timing. How long has this been going on? When did these symptoms begin? And what was the precipitant to this trauma or stressor? And how long has it been going on? And is this acute versus chronic? What the answers to those questions are going to help you distinguish ASD, PTSD, and OCD spectrum. The other thing is you want to figure out what is the phenomenological pattern of this. Is it intrusive, thought linked to an actual event like trauma recall, or is it symbolic and fear obsessed? And then also, are these behaviors aimed at neutralizing anxiety or avoiding triggers? How much insight is in there? This is the thought that's recognized as unreasonable. Is this believed to be true? And what are the arousal and autonomic signs and symptoms? Like, how do you know you're anxious, right? They come to you with, I'm anxious or I have PTSD. And you say, well, how do you know? And you're listening for heart rate variability, sleep disruption, hypervigilance, exaggerated startle, panic, that sort of thing. These are the fear circuits that are activated. You're listening for that because if that's paramount, you might be thinking SSRIs or adrenergic agents, beta blockers, the like. The other thing you're trying to assess for are what are the cognitive and developmental context as you tailor this assessment to the age and psychological development of the person you're contending with. Children will externalize the symptoms. Adolescents will try to hide the symptoms. Adults are going to try and rationalize the symptoms, and elderly will minimize or somatize. So who you're talking to will determine what they're saying to you, even though they could be describing the very same condition. And of course, the functional impact is important to tease out. What is your daily routine like? Tell me about your occupational performance, your interpersonal strains. Is there distress that is just merely subjective, or is there something I can objectively verify here? And the prognostic protection is that, are you flexible? The biggest tell of mental illness is mental rigidity. So if they're very rigid, that's a tell that something really severe is going to be hard to treat here. And you're looking for family support, resilience, willingness to engage with therapy. What is their explanatory model of how do they understand their symptoms? How they explain it will often predict therapeutic alliance, essentially. And so that's what you're trying to figure out. Now, again, you could use structured tools, narrative history, behavioral observation, and collateral. Those are the tools of psychiatry. And these are the tools I have shown you previously. All of these are available. There's some in the public domain. They're fairly versatile. But let's take a look here now at this clinical interview. So before they fill out a form or a scale, the clinical interview that you do, this is going to lay the groundwork. This is where the accuracy of diagnosis begins. It's not a checklist, but you do this curious containment and pacing to kind of elicit their story. The story matters, but the sequence matters more. So you want to start by identifying the index trauma or traumas, and then establish this chronological map. When did it begin? How often did it recur? How severe it was? And don't rush the disclosure process. Ask for themes before details. Document avoidance triggers. What the patient doesn't want to talk about will often reveal the most diagnostic information. Your goal here is not to make them relive it. So it's to understand how they have adapted and learned to survive with it. That's what you're really going after. They don't need to hear all the gory details. And before you explore the past, you need to secure the present. So always assess for suicidal and homicidal ideations, but you need to go beyond yes or no. Explore intent, plan, means, ambivalence, history of self-harm behaviors, including non-suicidal, self-injurious behaviors, and also their environmental safety. What are the ongoing threats? Domestic violence, lack of social support. Because if the danger is current, you want to stabilize that before you make them emotionally unstable and rehash what has caused this level of distress. Now, you want to quantify their functional impairment. Trauma and OCD tend to steal a lot of time, but in different ways. So occupational and social functioning, such as missed work, academic decline, isolation. And another thing is to inquire, what's a typical day like for you? Well, it's different. Well, okay, tell me what a weekday and a weekend and a holiday. What is sleep, appetite, hygiene, energy levels? You want to determine whether the impairment stems from the intrusive distress, that is the trauma, or a ritualized control of behaviors, that is the OCD. Because the functional data that you elicit becomes your outcome metric. So how are you sleeping now? Good, that's what I can measure. Because if they've built an identity around the diagnosis, they may be reluctant to let the diagnosis go. But if you can objectively measure symptoms that are diminishing, That is how you can know if you're moving in the right direction. The other thing, of course, is to always screen for comorbidities because no one's ever walking along with one diagnosis. Screen broadly for mood disorders, anxiety disorders, substance use disorders, medical comorbidities, thyroid, head injury, chronic pain, chest pain, all of those, cardiovascular symptoms, family history. All of those tend to run in predictable pattern clusters. So don't just identify the primary disorder, you have to figure out what's going along with it, because it may be a perpetuating factor. It's like this is science and hospitality. I invite you to tell me your story, and I want to help you contain this chaos so that I can translate it into something that can be treated, because you're going to get very overwhelmed by the stories you hear. Okay, so here is the 4P formulation revisited. Here's a little case that we have here about a combat veteran. So James is a 32-year-old combat veteran who presents with flashbacks, nightmares, hypervigilance, and emotional numbing after deployment. So let's think about the 4Ps allowed here. So the predisposing factors: family history of anxiety, early trauma, personality traits like high conscientiousness. These create a nervous system primed for hyperarousal and self-blame. Now we look at the precipitating factors here: exposure to life-threatening combat, precipitant; witnessing death, moral injury, the event that transforms the vulnerability into the disorder, that's the precipitant. Now, what kept it from resolving? What's perpetuating this thing? Avoidance behaviors, alcohol use, disrupted sleep, social withdrawal, unemployment. Every avoidance behavior that you are identifying is relieving some sort of short-term distress, but inadvertently reinforcing this long-term pattern. Now, we don't want to throw it all down the drain. We want to capitalize and promote these protective factors like what? Does he have a supportive spouse, good physical routine, veteran peer support group? Not just side notes, this is the leverage that you're going to use for recovery. So in James's case, the path forward starts not just with symptom management alone, but with restoring contact, both physiological regulation and social reconnection. The next case you have next to it here is this 15-year-old Maya with, she spends over 3 hours a day hand washing with intrusive thoughts of contamination and reassurance seeking from parents. Now, the predisposing factors here could be like family anxiety traits, perfectionism, possible pandas. So you're looking for biological and cognitive rigidity. This is what creates that fertile ground for this behavior to manifest. Now, precipitating, there was a cousin that was hospitalized, and there's academic stress and media exposure to illness. So this is the anxiety attaches to a concrete symbol, such as, in this case, contamination. And what keeps this going is the parental reassurance and the ritual accommodation that's happened in her family. So each time they help, they unintentionally strengthen the cycle. But what are her protective factors? We can't negate those. So high insight, she knows there's a problem. Engaged parents, they want to really help. Good cognitive capacity, a supportive counselor. So this treatment success is going to depend on channeling these assets, if you will, into some sort of exposure reprocessing response process. So in both cases, the protective factors are the hinge. Now, without them, then these other 3Ps are going to stay locked in place. I mean, we can't change predisposing and precipitants, but we can certainly focus on the perpetuating factor. So every patient has all 4Ps, and your job is to identify which perpetuating factor is keeping this from resolving. All right, let's talk about some of the psychotherapeutic interventions here. So they have a problem, and the next question is, well, what do we do about it? And so we want to look at things like both trauma and OCD are disorders of a dysregulated fear and learning and a maladaptive avoidance pattern. So effective psychotherapy has to do two things here. I need to, one, reestablish safety through controlled exposure. Because if you're afraid of something, we can't keep avoiding it because that's going to entrench it. And two, I need to rewire the meaning through new associations and cognitive restructuring. So that's what we're going to get into now. Okay, so let's look at some of these psychotherapies that are popular and readily available. So when the problem is fear-based and avoidant, exposure is going to become your antidote. And what we're trying to do here is teach extinction. And this is the gold standard for PTSD. So when the trauma is discrete and the patient can tolerate revisiting it, we're going to try to retrain their amygdala to update the threat map. And we're going to use this when the trauma memory itself is driving the avoidance or the hypervigilance or the startle response. Patients think that exposure will make them fall apart, but in reality, it's the avoidance that's keeping them fragmented like this. The other type of psychotherapy is this exposure and response prevention. So ERP is to OCD what insulin is to diabetes, essentially. This is not optional. This is the treatment, and people will drop out if they're not willing to do this. And until they are, this is not going to get better. But the goal is not to eliminate the obsessional thought, but to break that compulsion anxiety relief loop. So this is ideal when a patient has good insight and can tolerate the distress. If there's no insight, this ain't going to go anywhere. And the principle here is the same. So exposure without escape. That's where the learning happens. And you're teaching the brain, you can have the thought and still be safe. Okay? And that's what you're doing with exposure response prevention. The other one is cognitive processing therapy. This is asking the question, what if the trauma isn't just about fear, but about meaning? This is targeting the maladaptive appraisals that they're making, guilt, shame, self-blame, the thing that keeps them psychologically alive. And this is best for things like moral injuries or complex trauma, survivor guilt, and things like that. This works through cognitive restructuring and a written impact statement. So this will integrate nicely when exposure feels too raw or diffuse. This is the therapy of why did I survive rather than what happened to me. And so you want to capitalize on their survival skills, essentially. EMDR is all the rage. Sometimes the patient can narrate, but the body remembers. So EMDR is intended to bypass language-based processing to engage in sensory integration and reconsolidation. This is best for patients with limited verbal access who shut down in narrative exposure. Evidence is strong for single incident traumas, but mixed for complex traumas. And think of this as like re-indexing a fragmented sensory file so that they stop auto-playing the loop. And then, of course, all these are combined, and we call this, if it doesn't fit the manual, there's emerging support for integrating these different therapies together. Hard to test, though. But every therapy is basically targeting the same triad. It's threat overestimation, control through avoidance, and impaired safety learning. So this is trying to figure out which one you're comfortable with, which fits the disorder, and that's the one you can proceed with. Okay, so trauma-focused CBT, when you think about trauma in children and adolescents, the question is, how do you help them confront with what has happened without re-traumatizing them? And so this trauma-focused CBT kind of blends exposure with emotional literacy and caregiver involvement to support their developmental age. So at its core, trauma-focused CBT will integrate cognitive behavioral therapy and family principles, and the sequence will follow this mnemonic called practice. And practice stands for psychoeducation and relaxation, affective modulation, cognitive coping, trauma narrative, in vivo exposure, conjoint sessions, and enhancing safety. So psychoeducation and relaxation, this is the normalize the trauma reaction and teach them somatic calming skills. Affective expression and cognitive coping, this is where you identify and label feelings and build thought and emotion connections. Trauma narrative in vivo exposure, this is where you do gradual storytelling to desensitize the trigger and eventually promote mastery. And then conjoined sessions and safety planning, this helps rebuild the attachment and ensure future security. The exposure here is nested in the relationship and play. The goal isn't to make them relive it, but to integrate the memory into a coherent story that they can control. And the target population, this was initially designed for children and adolescents ages 3 to 18 across all trauma types, sexual abuse, domestic violence, disaster, trauma, grief. Caregiver participation here is essential because the healing is said to happen through reattachment. Now, we have to look at some developmental tailoring strategies. So in young children, we want to use play, dolls, drawing, caregiver modeling. In school-age children, they're going to rely on pictures, metaphors, and simple cognitive links. Adolescence is where you introduce things like metacognition, meta-reasoning, autonomy. The younger the child, the more you externalize. The older, the more they can internalize. Okay. All right, now prolonged exposure therapy. This doesn't teach patients to forget their trauma. This teaches the brain that remembering is not the same thing as reliving. So first you start with things like imaginal exposure, that is revisiting the memory. The first form is imagination. So where the patient revisits this traumatic memory in a structured, controlled way. We're not going to re-traumatize them. We don't need to but we need to refile this memory in the proper spot. So what happens here is they narrate the event aloud, often while being recorded, and then listen to their recording between sessions to desensitize the emotional charge. Physiologically, this is going to recruit the hippocampus to recontextualize the memory and helps the amygdala relearn that the threat is no longer present. Then in vivo exposure, this is where the next, they confront the avoided situation in real life, from least to most distressing. And this is where, if it's a war zone, virtual reality can often play into this. So the idea is simple, but it's pretty a big deal if they can do it. Every avoided place, every avoided smell, sound, that's basically being held hostage to fear. So exposure is how you're going to negotiate their release. So often what happens is you're going to underestimate how subtle avoidance can be sitting with your back to the wall, avoiding certain streets, keeping the lights on. And in this prolonged exposure, you're targeting these micro avoidances that keep the nervous system in perpetual threat mode. Now, the protocol structure here is highly manualized. It takes a course over 8 to 15 weeks. It's about 60 to 90-minute sessions, and it includes psychoeducation, breath retraining, daily homework, because habituation is going to happen between the sessions, not in the session. So the homework is where that neural consolidation occurs, and without it, you're only doing emotional rehearsal, not rewiring. So you want them to practice this behavior. You have to be careful, though, because in cases of active suicidality or severe disassociation or ongoing trauma exposure, for substance-dependent patients, stabilization has to come first. You need enough cognitive bandwidth to stay engaged. So I don't do any sort of psychotherapy with someone that's actively using substances, because I can't do that. The brain is not stable to work with. This is important because exposure has to happen at a pace that activates anxiety enough, but doesn't cause them to shut down. So across dozens of randomized controlled trials, which I'm not exactly sure how you do it in this sort of thing, maybe sham therapy, 60 to 80% are thought to achieve significant symptom reduction at sustained follow-up. So this is definitely something that can work, but it has to be done effectively and in the right patient. So let's talk about this cognitive processing therapy here. So this is best if the problem isn't the fear anymore, but it's the story the person tells themselves about what happened. And this is where cognitive processing therapy comes in. So if you use prolonged exposure therapy to recalibrate the fear, this is rewriting the meaning of the script. So this starts with the idea of the stuck point, the rigid maladaptive belief that blocks the recovery. These are not random thoughts, they're interpretations of trauma that became self-blame loops. So for example, I should have done more. It's my fault they died. I can't trust anyone again. These beliefs reflect the hindsight bias, the illusion that we could have predicted or prevented trauma if only we'd been stronger, smarter, more cautious, etc. That's the bias that keeps this guilt and shame alive. So this is done by Socratic questioning. So your role is going to be like gently dismantling these beliefs through a structured inquiry. So you don't argue with them, you ask questions like, well, what evidence supports that belief? Would you hold someone else to the same standard? What did you realistically have control over? The goal is to generate balanced, reality-based alternatives. So if prolonged exposure is teaching emotional tolerance, this is trying to teach them some cognitive flexibility. Because remember, I told you the rigidity is the big hurdle to overcome. Most stuck points will fall into 4 belief domains, and they're remarkably consistent across all trauma survivors. And they all map directly to different attachment needs. So what you're noticing is trauma destabilizes the relational architecture of the self. So CPT typically done in 12 sessions. Education in the first 2 sessions where you explain the link between thoughts and emotions. And then in session 3, this is the impact statement where you have the client write down how the trauma changed their belief about themselves, others, and the world. And then you get to sessions 4 and 5, the stuck point identification, where you highlight patterns of guilt and overgeneralization and self-blame. Then you get to sessions 6 through 9, where you're doing examining the cognitive distortions embedded in the narrative. And then the final impact statement between sessions 10 through 12, where you revisit the initial belief and consolidate adaptive meaning and future goals. So this is not simply focused on insight. This is integration. The trauma becomes part of the story, not their identity. So when you hear a patient say it was my fault or I should have known, that's not just emotion, that's their theology. So CPT invites them to replace the condemnation with context so they can finally grieve. Hey, Joe, can you mute yourself, please? Thanks. So when people hear of EMDR, they often picture like hypnosis or some sort of magic eye waving thing. But really, what's happening here is a highly structured neurological reset. This is a way of teaching the brain that the danger is over. So this is 8 phases of EMDR, each one deliberately paced to balance activation with safety. And so you start with history and treatment planning, where you identify target memories and you're assessing their readiness. Not every client is immediately a candidate for this. Now, before you touch the trauma, you have to strengthen the container, the grounding, the bilateral breathing, the visualization. You have to become a co-regulator with them in this process. And you're going to try and pinpoint the target memory, the negative cognition where they felt, I'm powerless. And then you want to find the desired positive cognition where they said, I survived. I'm in control now. And then you go through a desensitization process where the bilateral stimulation begins, usually side-to-side eye movements, but you can do right and left clicking. There's a video on YouTube with EMDR, and you can just move your eyes back and forth on the screen. And what's happening here is during the bilateral stimulation, the client recalls the memory while the brain is said to be reprocessing it in small, tolerable doses. And then they go to installation phase where they install the positive cognition through continued stimulation, literally pairing new meaning with the old sensory trace. You'll teach them things like body scanning, and this is when the body often holds on to residue of what the mind has reprocessed. And you ask, where do you still feel it? And the session ends with stabilization. Every memory opened needs to be emotionally sealed before leaving the room. And at the next session, you review. So is the distress still active? Has the brain removed it into long-term integration? And the protocol is different. This is a very rigid protocol. It's not free form. EMDR without structure is said to just be distraction. So that's not what we want to do here. The core is all about the bilateral stimulation, alternating engagement of both hemispheres through eye movement, tones, and tactile pulses. This is like, think of it like REM sleep processing, but while awake. During REM, the brain's integrating the emotion, the memory. EMDR is trying to co-opt that same circuitry, activating both hemispheres of the brain and allowing for implicit memories to link with explicit context. And it's supposed to facilitate adaptive memory integration. The trauma becomes a narrative rather than a flashback. So it's less about forgetting and more about refiling, moving from memory in the limbic system to a filing cabinet in the cortex so you can deal with it. Okay. So you can go on for additional training in this if this is something you want to do. So let's talk about briefly here exposure and response prevention. So if prolonged exposure teaches the patient to face what they fear, exposure and response prevention teaches them to stop obeying what they fear. So this is not just about confronting the triggers, it's about refusing to perform the ritual that the anxiety demands as payment. So there's a hierarchy of development here. So ERP starts collaboratively. And what you do is you're going to try to build a fear hierarchy. And you're going to rank a list of triggers from the least to the most distressing using subjective units of distress from 0 to 100. And this hierarchy is going to create a roadmap for graded exposure so the process feels strategic rather than overwhelming. Now, it's critical to co-create this list because the patient has to own the sequence. ERP done to a patient becomes punishment. ERP done with the patient makes them feel empowered. So you want them to really develop this gradation. And what you're going to do is this gradual exposure where you systematically and repeatedly confront with the feared stimulus in a controlled setting. And the goal here is habituation, learning that anxiety rises, peaks, and falls on its own without the need for ritual reassurance. So you think of this as like metabolic conditioning for the nervous system. Each repetition is going to build tolerance, not trauma. Now, what we're preventing is the response. So this is the heart of this therapy. Exposure alone, not sufficient. The real change comes from when you prevent the ritualized response, whether that's washing, checking, counting, confessing, whatever that response is. When the patient resists the compulsion, they teach their brain that nothing catastrophic happens if they don't give in to this. And then each resisted ritual is considered a microdose of mastery. And then you want to habituate this process over time. So over time, anxiety will naturally decline, and you're not looking to erase the fear, but to extinguish the power. And this is the difference between feeling anxious and ruled by it. You know, I talked earlier about being a victim of our emotions. We want to avoid that. So ERP works across subtypes, each with its own logic of avoidance and reassurance seeking. So if the fear is contamination, what you're going to do is touch a contaminated surface and refrain from washing. If the fear is the symmetry ordering, then you're going to intentionally misalign objects and tolerate that discomfort. If it's a harm-related obsession, you're going to expose the trigger thoughts or images without checking for safety. And then each subtype will have the same pathology. Anxiety demands an action, and the compulsion becomes the counterfeit cure. So This is not for every patient or every moment. You have to avoid and modify in cases of patients with active psychosis, acute suicidality, or severe depression, or when reality testing is compromised. So, and for children or cognitively limited patients, you need to really simplify this, and often with a caregiver or somebody modeling this behavior. Family accommodation is common in kids, so parents are unintentionally reinforcing, so you really have to include them in the care. Okay, so we've covered the major evidence-based psychotherapy: CPT, PE, EMDR, ERP, and TFCBT. So this is how you're going to choose between them. So your initial assessment, primary diagnosis, you begin as always with a clear anchor. Is this PTSD or ASD on the trauma spectrum? Or is it OCD on the anxiety spectrum? The answer determines which dimension you assess next. So symptom profile for trauma-based disorders or insight level for OCD. For PTSD or acute stress, you're going to follow the symptom profile. Here, what matters is the patient's avoidance threshold and the complexity of the trauma. High avoidance, that's cognitive processing therapy. When a patient intellectualizes, overthinks, or shuts down when facing distress, start cognitively. You go with what they're using. CPT helps them approach the trauma through meaning first before tackling full exposure. If they're doing moderate avoidance, this is where you do prolonged exposure therapy for those with clear trauma memories who can tolerate activation. Prolonged exposure is optimal. It targets the fear structure directly through repeated exposures. If you're dealing with complex trauma, then this is your EMDR patient. When trauma is multi-layered or pre-verbal, EMDR is for them. And this accesses the nonverbal networks by bypassing the need for long narrative details. So CPT when avoidance is cognitive, PE when avoidance is behavioral, EMDR when the trauma is fragmented. Now for OCD, you want to follow the insight level. And here, the key variable is insight. How much the patient recognizes their thoughts as unreasonable. So if they have good insight, that's the exposure and response prevention. These are the patients that can engage directly in exposure work and resist the rituals conscientiously. If, however, they have poor insight or they're a pediatric case, then this is family ERP when the insight is limited or the child's rituals are sustained by the family's accommodation. Therapy has to include the caregiver here. The family system becomes both the intervention and the exposure context. There's some special considerations. Beneath both branches, you're going to see some modifiers, and these are the real-world adjustments you're going to have to make. So if there is substance use, integrated CBT. When trauma coexists with active substance use, you're going to have to integrate CBT addressing both avoidance and relapse cycles simultaneously. If you're dealing with young children, this is the trauma-focused CBT with the caregiver. For younger children, play-based trauma-focused CBT, and that allows for regulation through the caregiver's nervous system because anxiety can be contagious. If you're dealing with older adults, you're going to do adapted PE and ERP. In older adults, you go at a slower pace, use shorter sessions with more repetition, and adapt the exposure for their cognitive or medical limitations. Okay. All right, let's hit psychopharmacology briefly. We won't spend a lot of time on this because you have a whole course in psychopharm, but in general, we're going to look at some first-line evidence-based practice for this. This is not a substitute for therapy, but typically when you see a psych NP or a psychiatrist, medications are going to be part of this. A lot of other people can do psychotherapy and all these different modalities, and you will find because your prescriptive abilities is a limited resource, you will often be put in the quote-unquote prescriber role, and it's just helpful for you to be aware of what therapies are out there and how you can help offer good synergy. So when you think about PTSD or OCD pharmacologically, you're not medicating emotions. What you have to think that you're doing is modulating neurocircuits. So you're dealing with trying to target the amygdala, the hippocampus, and the prefrontal cortex. And this triad of dysregulation has fired off in this trauma response. So what we're going to focus on here is which pharmacologic classes have the strongest evidence for PTSD, OCD. And then we're going to figure out how do we think strategically about medication choice when psychotherapy alone is not enough. So the same reasoning that guided your therapy selection is going to guide the symptom profile and tolerance to choose. Okay, so here we go. So when you treat PTSD pharmacologically, the goal is not sedation, it's stabilization. So you're targeting an overactive amygdala or underactivation of the prefrontal cortex or a dysregulated serotonin norepinephrine signaling that's driving this hyperarousal intrusive re-experiencing. So SSRIs and SNRIs, these are the foundational first-line agents in this condition. These are the mainstays. According to various sources, APA, VA, DOD, it's the strongest evidence for things like sertraline, fluoxetine, venlafaxine. I don't recommend paroxetine, but I put it on there because people are still on it. The half-life is too short and people go into withdrawal if they miss just one dose. So I don't recommend Paxil paroxetine, but it's popular. It's still in use. It's generic, but I don't recommend it. We like something with a longer half-life. Zoloft, sertraline, you're going to start low and you're going to go upwards to about 200 milligrams a day eventually. It's approved for PTSD, tends to be better tolerated, but if you start too high, you'll never get past the GI side effects and then they'll say it's not working and they're done. So start sertraline with comorbid anxiety or irritability. This is going to smooth out their emotional reactivity. If you use Prozac, it's technically off-label, but it's good because of the long half-life, so we don't worry too much about withdrawal side effects. It's stimulating, so it's good for anyone that has a low energy presentation or comorbid depression. Makes it easier to come off of, so patients want to think about coming off meds. That's a good one to start with. So venlafaxine is generally SSRI in the lower doses until you get to the higher doses of over, say, 150. You don't hit SNRI range. But it's a dual action drug. So you want to watch for activation syndrome in the first 1 to 2 weeks, especially with titrations. You want to watch for suicidality in young adults. It's rare, but you need to pay attention to it. And you want to pay attention to symptom tracking. So you want to pick a tool that you can do at baseline and then at follow-up visits. In PTSD, we have Precipitating, which is an alpha blocker, mirtazapine, and the atypical antipsychotics. Precipitating remains the most effective for trauma-related nightmares. You want to start at 1 milligram at bedtime and titrate slowly. Mirtazapine, this is a tetracyclic antidepressant with a dual role. This is good for sleep and appetite. And then the atypical antipsychotics is good for treatment-resistant cases. Start low and slowly titrate. Quetiapine is the preferred, among the least metabolically deranging, so you want to make sure you don't cause more harm. And you want to go up gradually. You don't want them to be numbed out. You just want just enough anxiety so they can learn some adaptive skills, and you gradually will turn down the dose. OCD pharmacology, again, is very similar with SSRIs, and then sometimes for treatment resistance, they may augment with antipsychotics. And it takes a long time to see effect, 10 to 12 weeks. This works okay with supportive therapy as well. Okay. So those are the disorders, the differential diagnosis and the frameworks. And now we need to integrate. So we'll do some cases as we move forward. And you'll see how these differentials and therapies and medications can all kind of work together. All right. So here's our first case here. We have Michael, who's a 29-year-old Army veteran who presents with intrusive memories of an IED explosion that killed members of his squad. He's having nightmares, avoidance, hypervigilance, emotional numbing, and heavy nightly drinking. He's lost his job after multiple angry outbursts. So what's really happening here? So if we go through this 4P formulation, this diagnostic scaffolding, this is going to give us a picture. So let's look here at his predisposing factors. First, what loaded the gun before the trauma ever happened? Biologically, he has a family history of alcohol use disorder and a prior mild concussion. So vulnerabilities in both the reward and the arousal system. Psychologically, perfectionism and military hypervigilance training create this rigidity that makes his emotional regulation difficult outside of structured environments. And socially, an unstable childhood and the stoicism of military culture have trained him to suppress rather than process emotion. So, in short, his system is conditioned for alertness and not recovery. So, what is the precipitant? What pulled the trigger here? That's the IED blast and the deaths of his fellow soldiers. These are the clear precipitants, but look at the moral layer of moral injury here. This is not just trauma, this is a collapse of meaning. And when the trauma is tied to a moral conflict, this resists the extinction through exposure alone. And then in an abrupt transition to civilian life, he went from a hyper-structured world to ambiguity and a loss of purpose. And this is considered another shock to the system. So what has kept us going? What's perpetuating this? What keeps this fire burning? Well, alcohol is the big one, because this in and of itself is fragmenting the REM sleep, which is blocking memory consolidation and amplifying the amygdala and hyperactivity. Avoidance behaviors, right? Reinforcing the anxiety. Every skipped exposure teaches the brain that the world is an unsafe place. You have social isolation and unemployment. That's tightening the loop. There's fewer corrective experiences in his life. There's less reward feedback, and he's left with more time to ruminate. So his PTSD isn't just persistent, it's maintained through a self-reinforcing cycle of avoidance and hyper-arousal. Well, does he have any protective factors? Well, every system has a stabilizer. He exercises regularly. He has insight to his impairment and a supportive spouse for now. And these are protective anchors which can help leverage some treatment. So what does the plan look like then for someone like him? How do you translate this understanding to intervention? So given his re-experiencing and avoidance patterns, the anchor therapy here is going to be prolonged exposure. So 12 weekly sessions using both imaginal and in vivo exposure. And then you pair this with breathing retraining to modulate the arousal. Pharmacologically, sertraline can be a first-line agent. Start 25 milligrams, work your way up, and you can use the PCL5 as a baseline and then tracking. And at the same time, you want to implement sleep hygiene protocol and gradual alcohol reduction plan versus maybe a detox. But I don't know that it's going to be a good idea to pull them out of this and go into a detox, because no amount of therapy is going to extinguish these memories if the REM sleep remains disrupted here. And finally, you're going to have to involve the spouse in therapy and connect him to some sort of veteran peer group, not as support groups, but as re-regulation networks, because nobody is calling him on his nonsense. There's no auto-correction here. He doesn't just need safety. He needs to feel like he belongs. So the 4P framework directly informs your treatment. Predisposing, that guides the psychoeducation and insight work. Precipitating, this targets the core trauma memories. Perpetuating factors, this defines what needs to change first. And the protective factors tells us where to begin his healing process and what you're going to reinforce. Let's see what survivor's guilt, that's the processing that needs to occur. That's perpetuating. He continues to ruminate that. Okay, let's take a look here at Emma. So read over Emma's case there. Emma's a 15-year-old high school sophomore, presents with severe contamination fears. So Emma's case here illustrates how obsession and compulsion become a family affair. So what you see here, parents are opening doors, providing the sanitizer, helping her avoid the triggers, all well-intentioned behaviors, reinforcing the cycle. Now, her fear here is real, but the threat is imagined, and her family has started orbiting around that imagination. So notice that the timeline, the symptoms developed over about 8 months with a clear escalation. Now, that tells us this is not a transient phase of adolescent anxiety. This is a feedback loop that has become ingrained of fear and relief that has been conditioned over time. So take a look here at what her predisposing factors are. Genetically, Emma carries a loaded deck. She's got a family history of OCD and GAD. Psychologically, she's a perfectionist, conscientious, intolerant of uncertainty. Traits that look adaptive in high-achieving families until anxiety turns them against the self. Socially, she's a high-pressure academic in a high environment where order and control are praised. So compulsions initially are masquerading as discipline. Now, the precipitating factor here, what flipped the switch? She looks like she had a recent streptococcal infection, perhaps triggering some sort of neuroimmune cascade, sometimes like pandas. Adding in social contagion, panda-related media, and a heightened germ awareness and hospitalized classmates, and the cognitive scaffolding of contamination fear has just built on itself. So biology opened the door, and then psychology locks it. Now, what are the perpetuating factors where we're going to aim our interventions here? Well, once the disorder takes hold, the rituals take over. So you have sleep disruption, and you have parental accommodation, social withdrawal, maintaining this anxiety loop. And the short-term relief Emma gets from hand washing reinforces this compulsive behavior through the neurological striatum. So anxiety spikes, she performs the ritual, and the brain records temporary relief as proof of the necessity. So this is the crucial irony of OCD. Every act of control strengthens the thing that it's trying to suppress. Now, if we take a look here at her protective factors, she has some protective buffers. She has high insight, strong cognitive skills, and a supportive family who are willing to participate in treatment. So these are not small advantages. They are the scaffolding. So we have to include them because they have been the reinforcers. And OCD outcomes will improve dramatically when the parents become involved as co-therapists rather than a co-participant in the ritual. So what does the integrated treatment plan look like here? Well, you'll start with family-based ERP, gradually, systematically exposure with parallel parent training to reduce this accommodation they're doing. And then the parents learn to tolerate the child's distress rather than to rescue her from it. And in the child, you could use something like fluoxetine titrated to a therapeutic range over several weeks. The goal isn't sedation, it's to have increased cognitive flexibility so that the ERP can take hold. And then at school, coordination with counselors is going to be crucial because the goal is not elimination of all stressors, but you want to contain the environmental triggers so that ERP remains the primary area of learning. And you're going to track progress through a formal tool like the Y-box or a family accommodation scale or something like that. So what you'll see here is OCD in adolescence. This is not a sign of fragility. It's a sign that the brain has learned the wrong rule about safety. And so your job isn't to teach calm, it's to teach tolerance of uncertainty. So when the family, the school, and the clinician align around this principle, then recovery is no longer just, is it going to happen? It just becomes a process of relearning. It's much more empowering to just see it as a skill to relearn rather than a die that's been cast and this is your lot. Okay, so up until this point, we've looked at things like treatments somewhat separately, but now we got to integrate. Kirsten, you have a question?
Yeah, just really quickly, going back to Michael, why is sleep deprivation a precipitating, but survivor's
Perpetuating.
guilt is
Perpetuating.
perpetuating?
No, sleep is perpetuating. That's why we're going
Oh,
after
okay.
sleep. Yeah, sleep is perpetuating. Definitely perpetuating.
Got you. Okay.
Yeah. Yep.
Thank you.
Yep. So we want to integrate. So you're going to start with psychotherapy in general. And for PTSD, your options depend on the symptom profile. So PE when avoidance dominates, CPT when guilt or shame are driving, EMDR when verbal processing is limited or the trauma is fragmented. For OCD, ERP is the gold standard with CBT layered in to build like metacognitive awareness. And what you need to figure out is how do you match treatment to the person's neurocognitive readiness? And the patient would say severe disassociation is not going to tolerate exposure. A patient without significant insight is not going to benefit from pure cognitive work. So integration begins with what can the nervous system handle right now? And then medication, it's not about symptom eradication as much as just reducing the intensity of the symptom. And it's about stabilizing so that they can build enough, so they can actually sit still, quote unquote, long enough to learn the skill, apply it, habituate it, and then the medicine goes down. Okay, let's wrap this up. Okay, so special populations. So for veterans, trauma carries a moral weight, not just what's witnessed, but what was done or what couldn't have been prevented. So this is the essence of moral injury. Moral injury is a rupture between one's actions and one's values. Treatment isn't about reducing flashbacks, it's about restoring coherence between who they were, who they became, and who they still hope to be. First responders face this cumulative trauma effect, death by 1,000 exposures. They don't have the luxury of one discrete event. Every shift holds echoes of the last. So workplace stigma and what results is this profession trained to save lives, but unable to admit pain. And the role is to normalize help-seeking strength, not weakness. You'll see this in critical care nurses, ER nurses, EMTs, paramedics, firefighters, things like that. They just live for the adrenaline. When I worked in CT-ICU and stopped working ICU, I likely went through an adrenaline withdrawal phase, and I didn't know what the heck it was. I was like, nothing in life matters. Nobody's dying. The care doesn't matter anymore. What is this psych thing? Nothing's going on here. So every now and then I get a little withdrawal symptom. I need to go back through an ICU just to make myself feel better. But first responders we have to just normalize this help-seeking behavior. Refugees carry layered traumas. So they have persecution, displacement, loss of identity, and often silence around their pain. So these people have to learn to rebuild safety in a world that once proved unsafe to them. Cultural humility here isn't optional. This is the therapy. So you cannot treat what you don't respect. And then healthcare workers, welcome, my people. Here we all are. We all belong to this slide also. So if you face vicarious trauma, seeing it in somebody else, moral distress, identity erosion, when the system's demands conflict with your own ethics. So during crisis, we tell ourselves to power through. But that self-neglect over time becomes its own pathology. So we have to heal when you're permitted to basically be human again. Okay. So these trauma-informed principles, these are across all domains, all groups. So safety, predictability, and honesty calm the nervous system more than reassurance ever can. Trustworthiness, this is where you keep your word, explain your rationale, and narrate the uncertainty rather than pretending control. Collaboration, this is the healing happens with not two, but you invite the patient into decisions. Your goal is to restore agency, and that becomes the antidote to the trauma, because if you think back, it was a time of powerlessness. And then empowerment, this is end every encounter by reminding patients that they did what they did that helped, not what you prescribed. So you did the work, not my Zoloft. That's really what you're aiming for. So these are the modern principles of ethics and psychiatry of trauma-informed care. It's a way of being with another person's story. Okay, So let's end this with a few issues of pattern recognition here. So first, you always want to distinguish OCD from psychosis. In OCD, patients know their thoughts are irrational. In psychosis, they believe them. The single insight, preserved or lost, defines the differential. Second, you need to remember that PTSD nightmares often respond to prazosin, but OCD requires higher SSRI dosing than depression. And if you underdose, you'll undertreat and mislabel the patient as resistant. So make sure you're getting the dosage right when the time comes. Third, in children, insight is under construction. So they may not articulate obsessions even as they perform the compulsion. So that's why family observation and developmental attunement are essentially indispensable. And never overlook the accommodations in the family. Families who rescue patients from distress are unwittingly reinforcing the illness. In PTSD and OCD alike, safety behaviors are sustaining the cycle. So if you remember only 3 things from today's lecture, be this. 1, use the 4P formulation. That's your compass. It's going to translate your symptoms into meaning and guide where you need to do what it is you need to do. Number 2, lead with the evidence-based psychotherapy and layer the pharmacotherapy where it supports. It does not replace the psychotherapy. And number 3, when the categories fail you, I want you to think about the RDoC framework, because consider the domains like threat processing, cognitive control, and arousal regulation, especially when they don't fit very neatly into a DSM criteria. That's how you'll understand these complex patients who don't check all of the boxes. And most of prescribing in psychiatry is off-label. So there are some resources on the screen there for further reference and study if you're interested. But ultimately, the best treatment you offer is going to be your capacity to see the person behind the pathology. So if you can do both, you will do well. So I will stop.